Hello again. In this talk, I would like to explore the causes of aniridia-associated keratopathy. Although aniridia-associated keratopathy is widely thought to be caused by a PAX6-driven congenital limbal stem cell deficiency, I argue that we really don't yet understand the cellular and molecular pathophysiological mechanisms underlying this disorder, and that this lack of understanding represents a fundamental gap in our knowledge. I'm not the only person to think this, but we are very much in the minority on this viewpoint. I assume that Professor Legale or others in this conference have already introduced aniridia-associated keratopathy, but in case not, aniridia-associated keratopathy is reported in 80% of individuals with aniridia worldwide. An example of this is shown in the panel to the upper left. In the patient group that I work with, which includes over 90 different families and more than 140 patients, this number is well over 95%. Therefore, the incidence of aniridia-associated keratopathy may vary in different populations. Aniridia-associated keratopathy often starts in children and gets progressively worse as they age. Aniridia-associated keratopathy is characterized by a progressive growth of fine blood vessels into the cornea, known as a corneal pannus, and progressive loss of corneal clarity. Additionally, individuals with aniridia experience recurrent erosions, corneal ulceration, subepithelial fibrosis, inflammation, and chronic pain. Importantly, the progressive opacification of the cornea results in a significant reduction of vision in those with aniridia. As I mentioned in my opening remarks, aniridia-associated keratopathy is widely thought to be caused by a PAX6-driven congenital limbal stem cell deficiency. A population of cells located in the limbus, known as limbal stem cells, shown here in the circled areas, maintain the corneal epithelium. These limbal stem cells produce daughter cells known as transient amplifying cells that migrate from the limbus into the cornea. As they migrate, the transient amplifying cells differentiate into the basal cells of the corneal epithelium. Damage or destruction of the limbus is causal for keratopathy in PAX6 normal individuals. The idea that aniridia-associated keratopathy was caused by a limbal stem cell deficiency originated with the results from the clinic and was based on 3 lines of evidence. First, the keratopathy appeared similar to that caused by the destruction of limbus in PAX6 normal individuals. Second, corneal transplants used to successfully restore the ocular surface in PAX6 normal individuals completely failed in aniridia patients. Third, and most importantly, the transplant of limbal tissue attached to a corneal scleral rim was able to restore the ocular surface in aniridia patients with a high degree of success as measured over a 5-year period of time. However, there is evidence in both children with aniridia and, as I'll show in just a few slides, a mouse model of aniridia that does not easily fit with the limbal stem cell deficiency hypothesis. On this slide, I'm showing 4 children with PAX6-mediated aniridia. These children are from different families and each has a different PAX6 mutation. I chose these individuals at random from a group of about 40 children in this age that are within our study group. All of the children here and those in our study group exhibit changes in the cornea. These include fluorescein uptake, generally in the peripheral area of the cornea, as you can see in the inset, small islands of cells with altered transparency or increased reflectiveness, increased stromal thickness as measured by optical coherence tomography, and a decrease in touch sensitivity. What I find to be interesting is that these corneal changes are present in a mostly clear cornea. This suggests, to me anyway, that most, if not all, of the ocular surface is being maintained by functioning stem cells. Additionally, the limbus in all of these children appear morphologically normal. To me, these and other observations suggest that aniridia-associated keratopathy may be triggered by pathological mechanisms other than a limbal stem cell deficiency. In the context of corneal progenitor cells, I wanted to share briefly with you the findings from our cellular phenotyping of cells from the human anterior segment. The single-cell RNA-seq data set that I'm showing you is a combination of data sets from my lab as well as those published by Collins et al. In 2021, Lee et al. In 2021, and Van Ziel et al. In 2022. The goal of this study was to try to identify a limbal stem cell population. Since limbal stem cells are thought to account for less than 1 to 2% of the proliferating basal epithelial cells, I wanted a data set large enough to have a chance of revealing a potential limbal stem cell population. What we found is that transient amplifying cells can be distinguished from committed basal cells by their expression of proliferation markers. The transient amplifying cells group within the basal epithelial clusters identified as corneal, limbal, and conjunctival, shown here in the circle. In our analyses, putative limbal progenitor cell or limbal stem cell markers fell into 3 categories. The first are those markers that are generally enriched in both limbal and conjunctival basal populations. ABCG2 is an example. Second, diffusely expressed in several clusters. BMI is an example. Or third, were not detectable. Our findings agree with those recently published by Josh Sains' lab. I next want to present some of the results from our attempts to test the limbal stem cell deficiency hypothesis using our mouse model of aniridia. I want to emphasize that none of the data that I'm going to show you actually rules out a limbal stem cell deficiency as the pathological mechanism underlying aniridia-associated keratopathy, but neither does it provide support for this hypothesis. I would like to introduce our aniridia mouse model. These animals carry a splice junction mutation at the 3' end of exon 10. This mutation was first described by Robert Hill in 1991. This mutation generates a premature stop codon, and the allele behaves as a null. For simplicity, I'm going to refer to this allele as small I or say. As a comparison for the range of eye phenotypes observed in the PAX6 mutant mice, I want to start with a clinical photograph of a typical looking PAX6 normal mouse from this line. Our normal mice have a normal globe size, a clear cornea, a fully developed iris, normal pupil shape, and a clear lens. These mice, normal mice, do not develop keratopathy. On the other hand, the small eye mice have a range of microphthalmic eye phenotypes that range from mild to severe. As you can see in this gallery of photos, at 2.5 months of age, some small eye animals had a very mild pathology, like the photos of the children that I just showed, and others had a more severe pathology. I'm showing a mild form of the pathology in the current box, the animal in the upper left, and here is one of the most severe pathologies that include prominent fibrosis and vascularization. The table summarizes our ophthalmic exam findings in our small eye mice at 2 to 3 months of age. As you can see, most of the mice were microphthalmic with iris hyperplasia and some evidence of corneal opacity. A large proportion also had cataracts and some evidence of corneal vascularization. None of the ophthalmic exams of the small eye mice were normal. In small eye mice, like humans, the corneal stroma is thicker and the corneal epithelium is thinner than for PAX6 normal mice, as can be seen in these histological images. In most corneas from small eye mice at 2 to 4 months of age, and this is 31 out of 39 animals, we find the presence of goblet cells, here marked by arrows and the pink PAS-H staining. But what I want to emphasize is that most of the other cells are corneal epithelial cells as measured by PAX6 labeling, which I'm not showing you, and cytokeratin 12 expression, which I'll show you in a second. We think that goblet cell formation may represent abnormal epithelial differentiation that is secondary to a PAX6 deficiency. In our small eye mice, we also routinely see an anterior cortical cataract, which is likely due to the poor separation of the lens from the overlying surface ectoderm during lens development. The pink staining in these photomicrographs is due to the presence of periodic acid shift positive material. Despite the presence of goblet cells and regions of stromal fibrosis, most of the cells in the central cornea express high levels of the corneal epithelial marker cytokeratin 12, which is consistent with the presence of PAX6 expressing cells throughout the corneal epithelium. We have spent a lot of time assessing the expression of putative limbal stem cell markers in small eye mice compared to PAX6 normal animals. We have not found any statistical differences between these two genotypes for any marker using any method. For simplicity, I'm only showing a graphical representation based on numerous statistical counts. But the take-home message is that there's no significant difference in P63, ABCG2, BMI, or any of the other markers that we've looked at. As a different way of testing limbal stem cell function, we assessed wound healing in these mice. Wounding was performed using N-heptanol applied to the cornea by a soft tissue. The size of the wound was adjusted for eye size. After wounding, we used fluorescein stain and photography to document the size of the ulcer. We then used image analysis software to determine the amount of cornea wounded in each mouse. There were no differences in the proportion of cornea wounded between the two genotypes. This graph shows days to corneal wound healing in wild-type and small eye mice. As expected, on day 0, all mice were fluorescein positive, and similar results were observed on day 1 post-wounding. Although, as you can see, on days 2 and 3, the number of mice that were fluorescein positive was higher in the small eye group, the more important story here, I think, is that most small eye exhibited healing rates more comparable to PAX6 normal mice. There were no differences at 4 days post-wounding, and all corneal ulcers were completely healed by day 7. We next assessed if wound healing had any impact on the limbal stem cell population. Shown here are results for P63, but the outcome was the same for all putative limbal stem cell markers that we examined. There was no difference in P63 expression in non-wounded or wounded wild-type or small eye mice, either in the limbus or central cornea. Indeed, we've not been able to find any quantitative deficiency or depletion of limbal progenitor cells in the pathogenesis of AAK in our mouse model under any condition. So after years of testing the limbal stem cell hypothesis with no clear results, I have concluded that I need to change the way I think about the cellular and molecular mechanisms underlying aniridia-associated keratopathy. My new hypothesis is that PAX6 deficiency in the corneal epithelial cells alters the corneal microenvironment which underlies aniridia-associated keratopathy. I propose that we can test this hypothesis by studying the nerve fibers and inappropriate formation of blood vessels in the PAX6 deficient cornea. Before we look at the data from the mouse, I would like to first introduce the corneal nerves using this figure from a review published by Timo Turvo from the University of Helsinki and colleagues. The stromal nerves are in the stroma and have a thick appearance. These nerves extend radially in the cornea and have many branches. The stromal nerves project into the corneal epithelium to form the subbasal nerves. The subbasal nerves are thinner in appearance and are located between the basal cells of the corneal epithelium and the basement membrane, as is shown in this cartoon down to the bottom right. Fibers from the subbasal nerves bifurcate from the bundle and turn upwards into the epithelium. In our aniridia mouse model, we can see distinct differences in the patterns of subbasal nerves in animals 6 months of age or older. In PAX6 normal animals, the subbasal nerves appear as long fibers running roughly radial into the central cornea, where they exhibit a swirl pattern in the central cornea. In contrast, there are fewer subbasal nerves in the PAX6 mutant mice, and the fibers are shorter and appear disoriented. In this slide, We assess if there are differences in corneal nerve development between PAX6 normal and PAX6 mutant mice. Unlike humans, the mouse corneal epithelium becomes stratified after birth. Stratification really gets underway after the mice open their eyes, which occurs at about 2 weeks after birth. Shown in the top panel of figures are the wild type, and the bottom are those from small eye. Interestingly, at birth, the patterns of stromal nerves appear to be the same between the two genotypes. At this stage, the corneal epithelium is a 2-cell layered thick, simple non-keratinized epithelium composed of basal cells and suprabasal cells. Differences in innervation are apparent at 2 weeks of development, which is the time period when the corneal epithelium is becoming stratified. We can see differences in both the stromal nerves, shown here in these two circles, these are the thicker nerves, as well as the suprabasal nerves, which are the finer nerves. By 4 weeks of development, when the adult stratification of the corneal epithelium is present in wild-type mice, PAX6 mutant mice exhibit a more similar pattern of innervation compared to those of the wild-type mice. This suggests that maturation of the corneal nerves is delayed in PAX6 mutant mice compared to their wild-type siblings. We next wanted to know if there was a change in corneal innervation associated with corneal opacification, and that's shown here. The top panels show corneal innervation as visualized using an antibody against beta-3 tubulin, and the lower panels represent the optical images of corneal opacity as measured by reflectance. As you can see, there is an increase in stromal fibers and a decrease in subbasal fibers in areas where the cornea is becoming opaque. This can be most easily seen by comparing these two corneas from small eye mice, where the one on the right is mostly opaque and the one on the left is still mostly translucent. As shown on this slide, we can see differences within the cornea that have regions that appear clear as well as some regions that appear cloudy. The cornea from the animal on the right is partially cloudy and partially translucent, and you can see that the innervation correlates with those two different regions. In addition to changes in corneal innervation, we see increased vascularization in regions that are becoming fibrotic, as is shown in this slide. We've got a wild-type animal on the left where you see very few blood vessels labeled in green, but the animal on the right, which has a partially clear and a partially cloudy cornea, exhibits high levels of labeling for both blood vessels and nerves, and these correlate with the fibrotic regions. What I'm not showing you is our data that indicates that there are changes in blood vessel formation and innervation that occur well before clinical evidence of progressive keratopathy. We think that our results support the idea that there are PAX6-dependent changes occurring in the corneas of people and mice with aniridia, and that these are separate from those associated with a more classic limbal stem cell deficiency. But we don't yet know what the mechanism is. Unfortunately, I cannot answer that question for you today, but I can share how we are identifying potential candidate pathways and some of our preliminary data. We do know that Notch signaling is upregulated in the small eye mouse cornea compared to wild type, and that this is related to blood vessel formation. As you can see in this slide, delta-like 4 expression is way up, as is the rest of Notch signaling, as measured by Hay1 expression. I showed this slide in my last talk. We are using RNA-seq, single-cell RNA-seq, and proteomics approaches to identify candidate pathways that could explain the changes in the corneal surface that we see in both mice and people with aniridia. We have identified several such candidates and are in the process of testing them. Hopefully, I can give a more mechanistic talk on this soon. The key takeaways from this talk are, first, most if not all children and young mice with aniridia exhibit subtle pathologies in the ocular surface. These pathologies cannot be easily explained by a classical limbal stem cell deficiency model. Some changes, like the corneal stroma, are due to changes in development. In newborn mice, corneal innervation is comparable between PAX6 normal and PAX6 deficient animals. However, changes in innervation are observed during stratification of the corneal epithelium. An increase in corneal stromal nerves and blood vessels correlates with areas of fibrosis. And finally, PAX6 deficient cells in the corneal epithelium exhibit different transcriptional signatures than PAX6 normal cells. Alterations in specific signaling pathways are suspected to contribute to the aniridia-associated keratopathy. I would like to thank the numerous people who worked on this project over the years, many of whom are listed here, the generous funding that supported this work, and all the individuals with aniridia and their families that have participated in our research. And finally, I would like to thank you for your kind attention. I'm happy to take questions via email.